Hello, dear chairmen, dear colleagues. At the beginning, I want to thank you, Professor Babić, for invitation and to congratulate the whole organizing committee for great symposium, and thank to all presenters for their great lectures. You know, it's not easy to stand here and talk after all your presentations, which was great. In next few minutes, I know it's Sunday, it's lunchtime, you are all a little bit tired with other things in your head, but I hope so you will have a little bit more energy, a little bit more concentration to hear my case in the next few minutes. As you know, Clinical Hospital Merkur is a leading liver transplant center in Croatia and one of the leading centers in Eurotransplant network, with approximately 100 transplants in per year. Of course, if we talk about pre-COVID period. If you ask me why I start my presentation with the liver on the acute cardiovascular care symposium, the answer is very simple: administration, administration, administration. In 2040, in our clinic, internal ICU was merged with the coronary care unit. At the first time, we were very shocked, but next day, the life goes on. Next day, we try to learn quickly as possible how to manage new pathology for us. At the first time, complication of the compensate liver cirrhosis and septical and infective states after transplantation of the liver, kidney and pancreas on immunosuppressive therapy, etc., etc. Today's case, a 70 years old female with known diagnosis of primary biliary cirrhosis with developed complication from 2012 year. 2018 she was candidate for liver transplantation on Eurotransplant list. Every year they need to do cardiac examination, so she had echo from 2090 with completely normal diameters of left ventricle and ejection fraction and mild aortic stenosis, mild mitral and tricuspidal regurgitation. Patient was admitted to our ICU with new onset of dyspnea and chest pain. In the Anamnesis medication, standard therapy for liver cirrhosis. In ECG, we found slightly elevated ST segment in V1 to V2 with severe increased levels of high sensitive troponin. On X-ray, we saw bilateral pleural effusion with pneumonic infiltrate, and echo that was performed in ICU shown reduced ejection fraction about 30% with hypoekinesis of distal parts of left ventricle. Respiratory status was bad, so patient was sedated, intubated and connected to mechanical ventilation. First question here is what to do to perform invasive or non-invasive strategy when we saw these findings. We choose a conservative expectative strategy. I will tell later why, and findings will be better next day. And we performed echo 5th day, and with completely regular movements of distal part of left ventricle with normal ejection fraction. 6 days, his respiratory status was better, and she was extubated. Why we didn't decide to do invasive coronary diagnostic? At the first, because of she's coagulopathy parameters. Second, high level of CRP and pneumonic infiltrate on X-ray. Then we look at the literature, and we found in papers that concomitant coronary artery disease in patient with Takotsubo cardiomyopathy is in range 10 to 29%. With echo criteria that motion abnormalities in patient with CAD usually extend beyond the territory of involved coronary artery after resolved of ejection fraction. What is with patient with Takotsubo and cirrhosis? Patient with cirrhosis usually demonstrate neurohumoral activation, increased cardiac output, and a compromised ventricular response to stress. As you know, autonomic dysfunction in primary biliary cirrhosis, which is reported in some papers, may be additional risk factor for cardiomyopathy. As you know, Takotsubo cardiomyopathy is associated with mechanisms that are not totally clear for us. First, as elevated serum catecholamine levels, epicardial coronary spasm, coronary microvascular impairment, and catecholamine radiotoxicity. According to main suggested mechanism and pathological changes in cirrhosis patients may have increased risk of development Takotsubo cardiomyopathy. In the literature, we found very small number of information of development Takotsubo in liver patients, especially in candidates for liver transplantation. And there are no sufficient clinical data available to guide the management of Takotsubo in the liver transplant population. Just couple reported cases of Takotsubo in which occurred perioperatively, not preoperatively. We found one report of Takotsubo in patient with acute liver failure secondary to Wilson disease, and in this specific case the diagnosis of Takotsubo was not considered as an absolute contraindication to transplant. In conclusion, according to clinical features, echo, ECG, and laboratory findings, our patient got over reversible Takotsubo cardiomyopathy with a complete recovered heart function. Because there are no strong recommendation on management of Takotsubo cardiomyopathy, at first there is not exact period of abstain from liver transplantation, and what are additional risks perioperatively in patients that have resolved Takotsubo cardiomyopathy. In our patient who got over Takotsubo cardiomyopathy with complete restored heart function, Takotsubo cardiomyopathy did not present any obstacle to liver transplant surgery. According to that, 3 weeks after Takotsubo, patient has undergone liver transplant without any cardiac complication, and she was discharged from the hospital 3 weeks after liver transplantation, and in perioperative period and the follow-up, there are no cardiac complications. Thank you.